Today we're going to talk about using learning agreements to enhance clinical learning. Learning agreements are designed to foster common understanding between students and preceptors of what needs to be accomplished in a rotation. The goal of a learning contract is to assess the knowledge and skill of rotating students, to set appropriate goals for the rotation, and to provide appropriate, helpful, face-to-face feedback to the student while creating a constructive learning environment. You should ideally do them on either the first or second day of any rotation. Ideally, you sit down with your student, briefly meet and discuss and collaborate on the learning agreement. Always begin with the end in mind. Learning agreements should consider each student's individual situation. Ask them what other rotations they've already done. Ask them what their interests are. For example, just ask them what type of doctor they are actually thinking about becoming. And it's always a good idea to find out what the student perceives as their particular strengths and or weaknesses. The learning agreement form asks some specific questions. There will be a section that will ask what skills or knowledge the student hopes to learn. Sometimes the student will have already filled in this section. If so, just review it so that you have a better idea of what the student hopes to gain from the rotation. The second section will ask what things you think the student needs to learn. For some of you, this may be the same from one to the next rotation. We do ask, however, that you consider the individual, their strengths, their weaknesses, their career interests, and their level of knowledge in your field so that you can tailor the learning contract to them. Based on the above things, what specific learning objectives do the student and preceptor agree that should be met in the rotation, and what activities will be most helpful to accomplish those objectives? Learning agreements for core rotations differ slightly from those for electives and selectives. For a core rotation learning agreement, there will already be learning objectives that have been pre-identified as being appropriate by the rotation chair. Just review those with the student. For those that are for the elective and selective rotation, it is up to you as the preceptor to discuss the appropriate learning emphasis and to write some learning objectives for that particular rotation. Learning objectives need to describe what the student will be able to do on completing the rotation. Ideally, they are learner-centered, focusing on the student, performance-based, focusing on what the student can and should be able to perform at the end of the rotation, outcome-focused, defined level of mastery is required, and please do keep in mind that our students are just that. They are either third or fourth year medical students, so it is important to be realistic about what an appropriate objective would be upon the completion of the rotation with you as their preceptor. An example of a good learning objective is the student will be able to assess the health risks of specific pediatric patients and formulate appropriate health promotion recommendations. Try to include a range of skill areas. Include cognitive or knowledge-related skills, procedural skills, technical skills, if that applies to your specialty, interpersonal, communication, documentation, and professional skills. Some other examples of appropriate learning objectives include the student will be able to correctly assess patients' alcohol abuse using the CAGE questions. This particular example includes communication, documentation, and interpersonal skill sets. The second one, the student will be able to intubate with minimum patient discomfort, includes both technical and procedural types of skill areas. The third one, the student will be able to orally present a patient case in a logical sequence, chronologically developing the present illness, summarizing pertinent findings, differential diagnosis, and plans for further testing and treatment. This particular objective covers a wide array of skill areas, but some include cognitive, communication, documentation, and professionalism. The cue words for the cognitive objectives are adapted from Bloom's taxonomy of learning. You can see here that on the very bottom are things that are basically requiring basic recall, knowledge, understanding. As we move up, however, to the green and blue sections, do consider some objectives that include these types of keywords for application, applying, calculating, classifying, predicting. For analysis, students should be asked to analyze, categorize, dissect, discriminate, and interpret. For the highest order in Bloom's taxonomy, we ask about synthesis and evaluation. Use words such as integrate, plan, create, design, invent. For evaluation, use words like critique, resolve, prioritize, support, and justify. Refer to the learning agreement when giving feedback to the student, especially at the mid-rotation and the end-of-rotation evaluation times. It is very important that when your student brings the learning agreement to you and you fill it out, sign it, and the student signs it, that you also get a copy of the learning agreement and keep it on hand for the duration of that student's rotation. It's probably not a bad idea to keep the learning agreement for several months after the student has rotated, just in case you need to refer back to it at a later date. At this time, we're going to show you a very general, simple example of how a learning agreement can be conducted with a student. Come in.
Good morning, Dr. Tom.
Hey, Lauren, how are you?
Good. I was wondering if you had a class.
I do. How's your first day going?
It's going really well.
Good. Come on over. So what's going on?
So what I have here is what we call a learning contract. So we're
Okay.
supposed to present it to our preceptors within the first few days of the rotation.
Okay.
And our school kind of gives us learning objectives of what we need to do while we're on the rotation. And then we are able to present what we wish to emphasize. And on the back, it gives us what the preceptor believes we should emphasize. And then we can go together and kind of create objectives as to how we're going to accomplish all this throughout the next few weeks.
So that sounds great. That will really help kind of focus your learning a little bit this month. I guess my first question would be, what other rotations have you done?
I have done internal medicine and surgery so far.
Okay, so a little bit different from what you're going to be doing this month, right? And what field are you interested in? What do you think you're going to do when you finish medical school?
Eventually physical medicine rehabilitation.
So PM&R, all right. And just in general, what do you think of as your strengths and as your weaknesses when it comes to learning or even clinical experience? What do you think?
Usually I'm very good with the patient interview. It's afterwards what to do, how to create the plan, the differential diagnosis. I still need a little work in that area.
Okay. And any strengths?
Usually talking is usually very natural for me, so to be able to relate to the patient and have a conversation is pretty easy.
So that will serve you well here, right? All right. So I think that's very helpful for me to understand, so that as we put together these learning objectives for the month, we'll have a little bit of information that's more specific to you, so we can kind of individualize it. It looks like the objectives for the rotation are here, and those look very much like the ones from the syllabus, so let's just review those quickly, so that we'll have at least a foundation to start with. The first one says demonstrate knowledge and understanding of biomedical concepts, human development, patient care, basic techniques related to psychiatric patient care setting. That's a lot. We could just stick with that first one, right? But there's several more to look at. So we will work towards definitely conceptual learning of what a practice in psychiatry looks like, to effectively counsel and instruct patients regarding specific diagnoses, treatment plans, broader issues of self-care and health maintenance. I do know from precepting before that one of the specific end-of-rotation evaluation pieces has to do with health maintenance and preventative medicine. So we'll talk about that with the patients that we see, and then you and I will talk about it too between patients. building productive relationships with patients, families, other healthcare professionals. I don't know if you've noticed so far today, it is your first day, but we're very multidisciplinary in nature. So you'll work with PAs and nurse practitioners and LCSWs or social workers and counselors, and it's a large team of people that actually come together to take care of the individual patient. So I think that's very important for this rotation to see how all those different roles fit together and function for the greater good of the patient, of course. Formulate and document appropriate diagnoses and treatment plans. You mentioned that you're good at collecting it, but then figuring out how to put it all together. So I think that should be somewhere in our objectives. Working towards being able to do that pretty seamlessly, and that will serve you well in any area of medicine. You're going to have to do that quite often as an intern or resident. Using and applying osteopathic principles and OMN to the psychiatric patient care setting, as much as you're comfortable with is great, and as much, of course, as the patient is comfortable with is fine. I have had students who get up in the middle of the session and offer to, do an OMN maneuver or technique for the patient right then. I've had other students who never offer. so again, that's up to your comfort level and up to the patient's comfort with having it done.
Would you be suggestive of patients that may be open to it before?
I would. I can tell you which ones. Again, seeing mostly children and adolescents, it's a little different. Sometimes I don't know which ones. I've certainly had parents who have asked, can they do that for me?
Yes.
I do, and again, that's up to your comfort level as well, but I hesitate a little there.
Yes.
But as long as the parent is okay and the kid says, that they have a specific issue, I think it's fine. So that will be very helpful too. Assess, assimilate, apply medical and research literature within psychiatry. We'll talk a little bit about the journal clubs that we have and how we do look for what is the latest sort of cutting edge literature, articles, research in the field that are applicable, bless you, to our patients. We will evaluate risks, benefits, limitations, costs of different diagnostic and treatment options associated with the care of the patients. That's just important in general. You'll hear over and over again the side effect profile of medication, the expense, the cost to the patient. If they're uninsured, we frequently go with generic medications and things like that. And the last one, it says demonstrating knowledge of the business aspect of managing patients with mental illness, billing, scheduling, patient flow, effective referral, and cost-effective medication. We just kind of discussed that. That's something that if you have specific questions about it, I encourage you to ask. Either ask me or ask my office manager, or you'll see sort of the ebb and flow of the office and how we kind of work people in and accommodate different patients. It is a little different in that in psychiatry we can't double and triple and quadruple book patients, so you won't see that kind of hectic pace here. Everyone has a slot, and if they show, we see them, and if they don't, we move on to the next one. But at least in my practice, we don't have the capability of double, triple booking, simply because the time has to be dedicated to the patient, and the later you wait and the later you see them, you get an angry patient who came for a therapeutic interaction, but when they come in, they're so upset because it's an hour after their appointed time. So we don't do that here, but in other practices, it's perfectly fine to do that. So we just, again, any questions that you have there, just let me know. So it looks like there's a section here about what skills or content you want to emphasize during the rotation. So give me some idea of what you're hoping to get.
So in my rotation so far, we have seen patients with psychiatric illnesses, and I would like to understand how to work that into a regular medical history. So to understand the difference between the regular medical history and the psychiatric history. And then especially how to do a psychiatric history in a child versus an adult. I'd also like to see what qualifies as an involuntary commitment and who can do that in the medical profession. Such, like if you're in the emergency room, for instance, who would you call and where would you find that information? And then how, when you're in a family practice or PM&R setting, especially for patients with chronic pain, how would you refer to psychiatry and what would you call that cutoff point, what you can manage and then what you should send to a psychiatrist?
So those are great objectives. Those will help very much to feed into the second part, right? So I guess this is the point at which I'm going to tell you what my thoughts are. And again, I have a template that I use with different students. So I was just looking over it when you came in. The skills and content that I believe should be emphasized, I really do believe common things being common. I'd like us to focus on, big picture diagnostic things like mood disorders, anxiety disorders, substance abuse. We're not going to see a lot of psychosis here because of the population I see being child and adolescent. But you will, with the nurse practitioners and the counselors and therapists, you will see adults who suffer from psychotic illness. So I think it is very important, again, if you're going into any field of, PM&R, family practice, you mentioned sort of the primary care perspective on mental health. I think it's important to understand, again, 85% of those who suffer from mood and anxiety never darken my doorstep.
Yes.
They go to their family practice physician, to any physician other than a psychiatrist to get their medication and their treatment. So it would be important to understand how to apply the diagnostic criteria for the big picture categories, how to do the differential diagnosis. You mentioned that sometimes you have an idea, but you need a little fleshing out there, I think. Also understanding common medical illnesses that either present as psychiatric illness or mask psychiatric illness.
Yes.
So all those due to general medical condition issues, we need to look into those a little deeper during the rotation. Of course, I want you to know how to do first and second line treatment for the big diagnoses for mood and anxiety. I'd like for you to understand the pharmacotherapy, the somatic treatment, and even some of the psychotherapy modalities that would be used.
Okay.
I think that's reasonable for during the month for you to pick up on some of those things. And we will, as best we can, talk a little bit as we see patients who are treatment resistant.
Okay.
We'll talk about why and why certain augmentation strategies are used or why certain other processes are being employed to help that patient get better. So again, common things being common, those are sort of the diagnoses that I'm looking at. As far as the skill set that I want you to be able to actually have when you leave the rotation, I do want you to be able to do a good psychiatric interview, a good mental status exam, and you mentioned you're good at relating to and talking to people, so I don't think rapport building will be that hard for you. But in general, talking to people about medical problems and issues is very different than talking to them about their emotional or their psychological issues. So you do have to develop a little bit of facility with how to approach that with a patient. And the best way I think to do that is, you kind of watch and learn from those of us who do it, and then you experiment with your own comfort level of trying it in different, different approaches with the patient. Understanding again that multidisciplinary aspect is important, and I know that you'll get that this month because we have a huge team that operates all together, and you'll see all the different ways in which they approach the patient, identify certain areas of concern, supplement or increase or add to the treatment plan. So you're going to get to see that. And then as far as some of your objectives went, you were wondering a little bit about how to do a child interview versus an adult. You will get to see that. Again, I see the children. Another provider here sees the adults. You're going to be able to compare and contrast those two. Understanding what qualifies for an involuntary, we will hammer safety the entire month, and you'll see people involuntarily committed from this facility, and then we'll talk about cases in other facilities. So I think you will get an idea of that. And as far as when to refer, again, it's all about comfort level. My preference is, and we'll talk when we see especially treatment-resistant patients, we will get an idea from them as to when their primary care physician thought it was getting to a point where they couldn't really handle it. For some, it's early in the process, depending on comfort level. For others, it's after several different combinations and trials of medication and somatic therapy, and it's all about comfort level. I have local internists, pediatricians, family practice docs who really go the extra 1 or 2 or 3 miles to manage the patient and keep them in what we call their patient home,
yes.
which is whoever they see as a primary care physician. I have others who, at the first hint of a psychiatric issue, refer them to me immediately.
Okay.
So I think, again, this month, one of the goals is for you to become comfortable enough that in your own practice, when you leave medical school, you do have some comfort in the management of patients, and you're not quite as quick to refer if it's something that can be taken care of easily by you. Okay? So I think those kind of match up. Are there any activities that you can think of that you would like for me to kind of focus on this month, or?
I would like to see how you do an initial visit, and then what you do, especially for children with ADHD. How working with the school and doing the learning contract with the school.
Okay, so, and you'll see that frequently,
Okay.
right? So I think that will be very good. So you will get to see that, and it might even be helpful. One of the activities might be to actually go with the child and family intervention specialists that we have in the school systems to actually see that side, the therapy that they do on site, and the way in which they act as a liaison between the psychiatric care provider, the school system, the parent, the child. I mean, that's kind of the person that puts all 4 of those pieces together and helps with the communication. So that might be a specific activity if you're interested in the school side of it and the consultation to the school. I think that can be done very easily. Some other things that we do, we will have a weekly journal club, so we will look at articles and research based on ideally the patient population that we're seeing. So you can pick a particularly interesting patient. It may be an adult patient that you're seeing with a nurse practitioner, it may be a kid or an adolescent that you're seeing with me, and then we will come up with an article or 2 to actually discuss each week. And ideally we will, again, keep in mind these objectives that we have, common things being common: mood disorders, anxiety disorders, substance abuse. That's what I hope you leave here having a good grasp of. So we might kind of further focus the journal club on that. With each patient, we will review their treatment and why certain drugs are being used, the side effects of certain drugs, drug-drug interactions. It's important that you have a nice sort of comfort level, again, with managing and using those medications. And if you don't go into psychiatry, that's fine. But a lot, and most of my students, as you know, don't, but a lot of times the only real experience you have in psychiatry is this month in your 3rd year. And so it's, this is where you're going to develop your comfort level and kind of decide a little bit about how easily you can manage a patient as an outpatient. We will talk about the rationale, the thought process behind why we use certain medications, not others, why we supplement or augment, etc. So it's important for you to walk away thinking, oh, now I understand a little better why there might be 2 or 3 instead of 1 medication. Oops, sorry. And then the student should interview the patients. I'd like for you independently to interview maybe 1 or 2 patients a week initially. And then as you develop, again, your comfort level, you can interview as many as you choose to. But I think that's where you're going to be able to then come back and put your thoughts together and then present the patient. And just with a lot of constructive criticism, we'll go through your presentation and determine ways it could have been better, ways it could have been, good strategies that you use to actually present the information, how we can make it more concise, more complete. I think that will be very helpful, and that was one of your objectives, to actually be able to do that. And then I think it would be a great idea to keep a patient log. And just with the patient's initials, obviously not a lot of identifying information, their diagnosis, and maybe just jot down a couple of the medications or the therapies that they're receiving. And then about 2 weeks in, I think it would be helpful to just look at your log and see where the deficits are. See what you've not been seeing enough of, see what you've been seeing way too much of, and we don't need to steer you in that direction anymore. I think that would help me and you to make sure that if we haven't seen enough of those, again, big picture diagnoses, then we can start moving in that direction. So those are the things that I have. Is there anything that you would like to add to what we might want to do for a skill or an activity?
I think for the first 2 weeks, that would be great activities to do. Maybe we could sit down again at the
Yes.
mid-rotation
Yes.
and talk more about what I haven't seen so far and
Yes.
what else we could do from that point out.
And I think it is suggested that we do that mid-rotation,
Okay.
feedback session. So you'll have to remind me though, when we get to the 2-week point, you remind me it's time for that mid-rotation review, and then we'll sit down and talk just exactly like you said. We'll see what's already been accomplished, what we still may need to work on for the remaining 2 weeks. And I should at that point also have some feedback as to how you're doing specifically, and if there's any areas for improvement. So I think we have a good plan though. It looks like we're supposed to both sign this, and so we'll do that. And if you wouldn't mind getting me a copy of this and giving it back to me just so that I'll have it for my file. And then when we do meet in a couple of weeks again, which I'll see you between now and then, but when we sit down again, I'll get this out and make sure that we kind of, stay true to what we've decided to do. Okay?
That sounds great.
All right. So we'll go ahead and sign on the dotted line. And since I threw my pen in the floor, I'll just use yours. All right. Thanks, Lauren.
Thank you so much.
I appreciate it. You're welcome.
I'll
Have a
see
great
you
rest of the day.
Saturday.
All right. I'll see you in clinic.